future nurse, and welcome back to our channel. Welcome back to this playlist, and I am glad that you're doing fine, doing good in your studies. Just keep going on, and I know you will reach your goals of becoming a successful nurse. So for this video lecture, continuing our playlist on community and infectious diseases, we are going to discuss um, malaria. So malaria is an infectious disease, but it's not contagious. Uh, that is arthropod borne, characterized by chills followed by fever occurring regular intervals, and it is caused by a protozoa, which is a plasmodium. And this plasmodium has four species strains. We have vivax, falciparum, malariae, and also ovale. Okay, and vivax is usually causing benign cases. For falciparum, this is the most frequently encountered uh, strain, species here in the Philippines, and it is considered the most fatal also. And the other hand, ovale is a rarely seen species, and its vector is a mosquito. So all know it's a female Anopheles mosquito. Compared to dengue, it's female Aedes aegypti mosquito, and it's completely different. For Anopheles, it's a night-biting mosquito. It breeds in clear, slow-moving water and usually found on rural areas, and it lands on a surface in a 45-degree angle. Speaking of the breeding places, usually it's on shaded streams, mountainous areas. It's usually color brown, angle in position, just like what's presented in the slide, and usually a reference would say does not bite a person in motion. Incubation period differs according to the strain. Uh, Based from a reference, Plasmodium falciparum is 12 to 14 days, Vivax is 13 to 17, Malaria is 28 to 30, and Ovale is 13 to 7 days also. So again, falciparum is the most common type in the Philippines and the most serious of the strains. It causes a very dangerous complication also, which I'll be presenting later. Vivax is more widely distributed. It causes benign tertian malaria, and this is the image of a mosquito Anopheles. Okay, so it's brown in color. So the mode of transmission of malaria is from the bite of an infected, again the word there is infected, female Anopheles. It can be also parenterally through blood transfusion of previously infected or a carrier of malaria, and although in rare occurrences, shared contaminated needles and placental transmission. The period of communicability is also different according to the strain, but generally it is infective, it's communicable as long as the gametocytes and asexual forms of the mosquito remains in the blood. Okay, that's how a person to person transmission may happen. Okay, So that's why I was um, presenting earlier parenteral transmission through blood transfusion and either occurrences shared contaminated needles and through placental transmission. Okay. If you happen to listen to your teachers before, what is usually discussed here is the mosquito life cycle. I mean the strain life cycle. Okay. At It is usually seen in a diagram because this is what happens. Okay. The life cycle of Plasmodium in man and in mosquito. Okay, so life cycle inside the mosquito, then being transferred to humans. That's when usually the Plasmodium attacks. And the basic pathophysiology of this, if in dengue it destroys the platelets, in malaria it destroys Plasmodium. I should say platelets, rather, platelets. So we have here a malaria endemic country, usually, or countries. Usually you can see it in a tropical region, including the Philippines. Okay, so the manifestations is or are classified into stages. And just like what I've said, the most characteristic pathology of malaria is the destruction of RBCs. Aside from that, is also upon imaging procedures, you will notice that the spleen of a patient with malaria is bigger than its normal size, meaning there is a hypertrophy of the spleen and also of the liver, and there is pigmentation of other organs of these organs, I should say, and this is due to the phagocytosis of the malarial pigments, which is released in the bloodstream upon rupture of the red blood cells. Okay, so the manifestations again are classified into stages. We have number one, the cold stage. This is manifested by chilling. Okay, and usually this change in the stages in malarial manifestations is brought about by the destruction of the RBCs. So if there is reduction of RBCs, thermal regulation inside the body changes. Okay, so chilling manifestations usually is from 10 to 15 minutes, and every manifestation, different sets of nursing interventions are also implemented. Just like in chilling stage or cold stage, of course, the responsibility here is to warm the patient. You may add covering, add clothing, offer warm drinks, hot water bags, and put on socks on lower extremities. So that's the chilling or the cold stage. This is another picture of the life cycle of a plasmodium. Then second is the hot stage, characterized by fever, headache, abdominal pain, and vomiting. Usually lasts for 4 to 6 hours. Responsibility here is, of course, lower the body temperature, the nearest normal one. Then TSB or tepid sponge bath. Then light loose clothing and antipyretics. So what you did in the first stage, somehow you reverse it. Okay, instead of putting additional clothes, you remove them. Right. Then there for the next stage, this is the sweating stage, the wet stage. Okay, The red stage, excessive sweating, feeling of weakness due to the past stages patient underwent. And our responsibility here is keep the patient comfortable, especially keep the patient dry with warm clothes, replace fluid loss, monitor vital signs, diet high calories, vitamins and minerals, fluid and electrolyte balance. Monitor vital signs is one of the regular assessments that you are going to do because of the change of stages, change of manifestations, and uh, just like what is taught to you, if a question is asked, what do you do first? That gives you a thinking that it should be an assessment. So one of it is monitoring of vital signs. So another um, life cycle from inside of a mosquito and outside of the mosquito on the other, in other words, inside already of the human body. So complications of Plasmodium falciparum, most dangerous one is one of the most dangerous one is a cerebral malaria. Once the infection reaches the brain, okay, it can cause cerebral malaria and it has a poor prognosis. It is really fatal. Others are hypoglycemia, severe anemia because red blood cells are destroyed, pulmonary edema, black water fever, which is usually the patient excretes or eliminates mahogany colored urine due to myoglobinuria, or simply, in other words, destruction of the uh, RBC. Okay, and the patient may have anuria until, if it's not corrected, the patient may die. Okay. So that's an image of a brain with from a patient with cerebral malaria. A diagnostic exam, the confirmatory one is malarial smear or your BSMP, blood smear malarial parasite. A blood smear malarial parasite. So this is usually taken at the height of the fever, because it's believed that it's a time that this Plasmodium attacks, okay, or most active. Okay, again, temperature of it is taken. Okay, the blood smear is taken during the height or the peak of the fever. Okay, this shows some signs of jaundice. Okay, conjunctiva of a patient. You also assess it. So you also check for signs of bleeding. Okay, further bleeding if it has already had bleeding. Then treatment, the drug of choice is chloroquine. Then we have also other medications related to it. Primaquine, quinine, sulfadoxine, Fansidar, the old one. Uh, I don't know if it's still used. Okay. And usually this is a multi-drug approach, especially if there is already resistance from the plasmodium. Okay. And speaking of medications, um, one of the advice here, if you are going to go to a malaria infested maybe country or province, you should have a prophylaxis of these chloroquines. One reference would say it should be taken um, before the visit, during the visit, and even after the visit. Okay. Although much is more emphasized on before and during visits. Okay. Additional management. closely monitor the patient, observe for deteriorations or unusual signs and symptoms, monitor the INO, um, or the intake and output, monitor serum bilirubin, BUN, creatinine, and also parasitic count or the BSMP, TSP, warm compress, and hot drinks. Depending on the stage, of course. But if it's in the cold stage, you may opt to have this intervention. Then provide comfort, increase fluids, especially on wet stage or diaphoretic stage. Keep the patient dry, and watch out for bleeding. Okay. If ever the client have developed cerebral malaria, consider it to be consider it to be an emergency, okay, situation. So the one reference would tell that we should administer IV quinine as, of course, in infusion, and also check for some toxicity of quinine like delirium, confusion, convulsions, and comatose state. And um, we're talking about really here of anemia, so watch out for the bleeding, watch out for jaundice, which is a sign of it. This is related to the density, okay, of the parasites in the bloodstream. Then evaluate the degree of anemia. You refer it to your physician. Watch out for abnormal bleeding that are maybe due to decreased production of clotting factors by the damaged liver. Okay, so aside from the spleen, the liver is also damaged, as we have mentioned earlier. In with regards to chemoprophylaxis or prophylaxis that I've been mentioning, some reference would say doxycycline is also used. This is usually taken 2 to 3 days prior to travel and continue up to 4 weeks upon leaving the area. So it's really before visiting the area, during, and after visiting the area. Okay, doxycycline, 100 milligrams per tab, 2 to 3 days prior to visit. That's a start. And we also have from one reference, mefloquine, no? Mefloquine, 250 milligrams per tab 1 week before travel and continue up to 4 weeks also upon leaving. Then also for pregnant women, especially if they are living in malaria infested areas, they should also have a chemo prophylaxis. One reference said that it should be during the first trimester, although we know that it is teratogenic, so it's better first if you consult your physician, your OB. Okay, so first trimester, chloroquine 2 tabs weekly, and 2 weeks before travel, during stay, and until 4 weeks after leaving if you're a visitor or you're pregnant and you plan to visit. Um, the simplest way to say it is chemoprophylaxis before, during, after the visit. Okay. Then additional measures for prevention, the clean program, if you still remember it. um, Chemically treated mosquito nets, I don't know if you're familiar with that. It usually comes from the arid shoe packed in a plastic. I don't know if it's color blue or pink, I'm not sure. Then report cases of malaria, screening, do screening. Then breeding places must be destroyed, although the breeding places are actually not that uh, destroyable, if that's a word, because we're talking about environment, right? So we're talking about rivers here, we're talking about mountains here, so it would be really difficult. Okay, just to go back with the clean program. C is chemically treated mosquito nets. L is larvae eating fish. E is environmental sanitation or environmental cleanup. A is anti-mosquito soap. And N is neem tea. Okay. Then, okay, we have mentioned already mosquito nets. Also spraying, okay, is one. Okay. Then insect repellents. Then blood donors should be screened very well. Though it will be difficult. Usually, you only ask for the history. Okay. Then since it's a nighttime, night biting mosquito, we usually advise people not to or to limit night activities or wear longer coverings or dress or clothes for them to prevent the bite of the mosquito. Okay, so that's the simplest way to my simplest way to present malaria. Okay, I hope you learn something or being refreshed by this video lecture, and always uh, despite of these difficult times, continue pondering. Okay, continue pushing for your dreams, for your goals of becoming a better person, and of course of being a nurse or a healthcare provider the best that you can be. So thank you.